Hi, my name is Aaron Gerds, and I'm the editor-in-chief of ASH Clinical News. We are here on site in sunny San Diego for our coverage of the ASH annual meeting for the year 2023, and it is my absolute pleasure to be joined today by Drs. Rampal and Pemmaraju to discuss the presentations of two amazing pivotal clinical trials done in myelofibrosis. These two abstracts were presented almost simultaneously at different oral abstract sessions. So we're here to bring the parties together to discuss what these trials mean going forward and how the field of myelofibrosis may change in the near future. So thank you so much for joining me today.
Thanks for having us.
All right, so we're gonna try to do a little bit of back and forth here, but just kind of fill folks in on the study, what was the population, and kind of some top line results. So Dr. Rampal, I'll start with you. What was the MANIFEST-2 trial, and what were the patients treated on that study?
Yeah, sure. So, MANIFEST-2 enrolled patients who previously were untreated with a JAK inhibitor and who had intermediate 1 or higher risk disease, which is an important distinction between the studies. And it, randomized patients to be treated with either the combination of pelabresib and ruxolitinib or ruxolitinib as a single agent. So that was the study design overall.
What was the study design for Transform-2? Transform-1, I'm sorry.
So for the Transform-1 study, Aaron, it was 252 patients overall, and also a phase 3 randomized global study, which was double-blinded, placebo-controlled, 1-to-1 randomization.
So two registration studies, effectively, right? Like these could serve as the basis for new drug approvals.
That's right.
And both in the frontline setting.
Right.
And
right.
So does this represent some sort of unmet need in myelofibrosis?
Without a doubt, right? Because look, we have JAK inhibitor therapies, they've made a big difference, right? Symptom-wise and spleen-wise, and probably in terms of survival. But if we look at the data as it exists from comfort and all that, it's not the majority of patients who are going to derive a benefit, right? If we think about the endpoints. And certainly these are not curative therapies, and our patients do usually come off of therapy and succumb to disease.
Mm-hmm. So in both of your presentations, which were absolutely fantastic, the top line results, the primary endpoint for each study was spleen volume response. So this shrinking of the spleen at week 24. And both studies were positive for that primary endpoint. But there's been a lot of discussion before the meeting and around the meeting about secondary endpoints, particularly symptom burden. So both trials showed that symptoms weren't certainly worse with the combination compared to just the ruxolitinib and placebo, but not necessarily statistically significantly better, right? So that term we sometimes throw around. So kind of what's your guys' take on measuring symptoms in patients with myelofibrosis, especially with the context of these two trials?
I may start for us. So on the Transform-1, as you mentioned, with the navitoclax combination, Aaron, the primary endpoint was met. And for both studies, really fairly close numbers, 60+% spleen volume reduction. As you know, SVR35 at week 24, the historical standard in our field, versus only 30+% in the control arm, which featured ruxolitinib plus placebo, and that's for both studies. Primary endpoint was met, done, end of story. But in our field, historically, at least with the JAK inhibitor monotherapy from the days of Comfort 1 and 2, we have always valued the patient experience and the symptom burden benefit. The bar was set quite high, as you well know, with Rux single agent. And so, as you said, in our study, Transform-1 with navitoclax, at least by statistical significance, we didn't meet the p-value of significance. But as I showed in the waterfall plots for our study, both groups had benefit, clinical benefit, symptom burden decrease, but it just wasn't meeting that statistical benchmark. I think, Aaron, when you add in a second drug, it's okay to say that we may be introducing a certain element of toxicity, side effects, as long as we're gaining some benefit for the patient, disease modification, and you're seeing that with this doubling of the spleen size reduction.
Was it, I know these were both week 24 analyses, but was there, the spleen volume reduction does indicate, significant impact on disease, but were there other kind of early signs of maybe some disease modification?
Yeah, I think so. And let me just say, I completely agree with everything Naveen said, right? I think, for combination therapy, traditionally in oncology, we worry about toxicity. What both studies are saying to us is that we're getting more biologic effect without incurring worsening symptoms in our patients. Right. That to me is a win. It's important, right? And I think with what we saw with the pelabresib study, clearly there was numerically better symptom control. The question is, what magnitude of symptom control is actually important for the patient? Now, there was data presented by Dr. Mesa here that suggested that with an anchoring analysis, you may be able to figure that out. But it raises the broader question in the field, is this the right endpoint for us to be looking at in these newer studies, these non-JAK inhibitor only studies, right? This is a different era than in the days of the COMFORT study. So I think that's one thing. But that brings us to the context of your question, right? Which is, are there other pieces of evidence that say to us that we are affecting the disease? And I think, from data that we showed in the pelabresib study, we're seeing a higher proportion of patients getting fibrosis reduction, right? We're seeing that hemoglobin actually improves in the cohort treated with the combination, higher rates of transfusion-independent patients, and also reduction in inflammatory cytokines. So I think in aggregate that says to us, okay, fine, with the spleen reduction, this is a biologically and clinically active drug. But it brings us back to the question, what then is the relevance of a TSS that is the same?
Yeah.
Well said.
I mean, I think that is just very strong evidence that the field needs to move on. And
Yes.
symptoms are important, quality of life needs to be measured, but in terms of judging the success of a therapeutic, we need to look at other things potentially.
Yes.
All right, so this next one's going to be a little tough. So I'm going to start with you, Naveen, because you're tough too.
That's right, Aaron.
So pretend you're Dr. Rampal sitting next to you, and what is your major in your scientifically evaluating Transform? What is the major weakness or criticism that you would give to Transform going forward?
Yeah, the field's been abuzz since our two presentations concluded yesterday evening at 6 p.m. And so this is the first joint interview we're doing. People are talking about, I would say, three major points. One is that these were two largely different study populations that we ended up investigating in these two large phase 3 studies. In Transform-1, it was mostly intermediate 2, so 80% of our patients were intermediate 2 risk, and then 48% of them, at least in the combination arm, were high molecular risk patients. I didn't show the breakdown of the mutations, but we all know what they are. So that's one thing that, and you can speak more about that, the populations were different. Number two, the numbers were different. Transform-1 study was 252 patients, whereas the pelabresib MANIFEST study was 400 plus patients. And then number three is that we showed certain factors of what you alluded to, including spleen volume, SVR35 durability at any time, which was remarkably 70+% in the combination versus only 40%. So that's even higher than the 60 and 30%. So some of the variables between the two studies were a bit different in what we're showing. Obviously, both studies are going to be followed for overall survival and some of these longer endpoints. The median follow-up time on the navitoclax study was 14.9 months. I think on your study, just a month or two shorter than that.
Yeah.
So there's a few differences between the two.
Yeah, I mean, if we kind of think about both, I think you're exactly right? These are slightly different patient populations. Right. On the other hand, the endpoint of the study is spleen volume response, which is not captured by the DIPSS, right? So we can say intermediate 1, intermediate 2, but is that relevant to the endpoint? It is not clear at all, right? And that's also true of the symptoms. In DIPSS, you either have them or you don't. It doesn't tell you how symptomatic you are. So, one could say, well, with the pelabresib study, these were largely intermediate risk patients, right? Intermediate 1 by far, at least 50% or so. Is that reflective of the patient population at need of treatment? I don't know, but the counter to that is, well, maybe we should be treating earlier. Maybe getting a deeper response earlier on does make a difference, right? So things for us to think about.
Yeah, no matter the disease, we've all had those patients who are multiple lines of therapy. It's very, very difficult to treat, and so potentially treating earlier, you can have a bigger impact. The question now that we have 4 JAK inhibitors FDA approved to treat myelofibrosis here in the United States, the room may be a little crowded, right? Do we have too many treatments? Definitely not. There is an unmet need, as you stated, but is there enough need in the frontline setting for 2 combination therapies? I'll open it to the floor.
I'll take a stab at it first for us. I think the short answer is yes. I think, as Raajit said in the beginning, while JAK inhibitor monotherapy revolutionized our field now over a decade plus from Surge and Claire's COMFORT-1 and COMFORT-2 studies, we didn't cure the vast majority of these patients. Almost no patient is going to be cured with JAK inhibitor monotherapy. Stem cell transplant remains the only curative. Number two is that Professor Palandri, our colleague in Italy, showed, and you were alluding to it, this is striking. In a retrospective review, 41%, almost half the patients at 3 years have stopped taking their JAK inhibitor RUX for various reasons, mostly because of adverse events, progression, only a few patients coming off for transplant. And then finally, we know from all of our groups that published that once you come off of the JAK inhibitor for either intolerance or resistance, sometimes that overall survival is measured in less than 2 years. So I believe, yes, we must modify the disease early if we can without the expense of too much toxicity, but we need to also let that translate into markers that matter for our patients: overall survival, PFS, EFS, LFS, bridge to stem cell transplant, blast reduction in the higher blast patients. So the answer to your question is yes. Number two, we have to figure out a way to do that that's patient-friendly, dose-friendly, cost-friendly, access-friendly.
Fantastic.
This is, the answer is yes, there's room for more than one, because the question is which patient is the best fit for which therapy.
Right.
We have no idea when it comes to any of our therapies, right? We can say, okay, cytopenic patients, maybe, there's certain JAK inhibitors we would favor, but, is there a molecular signal here? Is there a certain signature that enriches for patients who may do better than they would on JAK inhibitor? One example of this, to put this in real terms, is if you look at the MANIFEST-1 study, at least in the untreated patients, the patients who had ASXL1 mutations, which we know don't do well, and also come off of their JAK inhibitor earlier, they did very well with the combination therapy. Now, is that going to be true in the phase 3 trial? We need to find out. Are there going to be certain molecular subgroups who do particularly well with navitoclax? I don't know. We have to figure those things out, because I think there is an opportunity here to start to select subgroups who are going to benefit particularly with particular drugs.
Nice.
I feel like we're getting closer and closer to the age of what lung cancer does right now. They get the mutation profile, and you get this drug, you get that drug, and it's very, my lung cancer colleagues always talk about how it's, there's 20 lung cancers now, not just 2 that I learned when I was a fellow.
Yes.
And so it's really exciting to see the field move towards that, not just in myelofibrosis and MPNs, but just in all of hematology in general. But wonderful insight. I look forward to hearing more about these studies as they mature, as we do the additional analyses. It is so exciting to think that this disease, it didn't have any treatments up until just very recently in the history of the disease. That is really moving forward with such amazing therapy. So thank you so much for joining me today, and congratulations both on a job well done in these presentations, and again, look forward to hearing more in the future.
Thank you very much.
All right, and I would like to thank our audience for joining us today for this discussion. You can read about these abstracts as well as all of our on-site coverage, all in the pages of ASH Clinical News as well as on our website. So until next time, we'll see you later.